Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week in this program, I have a different guest, and we talk about different programs, services, opportunities that I think will be of interest to you and your family. I hope you'll stay tuned because right after these messages, I've got a great guest on the program today. We'll be right back. Welcome back to Your Health Matters. My guest today is Dr. Brent Bedke, who is our newest pathologist here at KRMC. Thanks for being on the show today.
Thanks, it's my pleasure.
And you are new to Kingman too, right?
I am. I've been here since July.
Wow. Now, did you have a family? Did they come too?
I do. So I'm married.
Okay.
And I have 3 children, ages 6, 4, and a year and a half.
Oh, fun.
Yes, very fun.
No dull moments at your house when you get to go home at night.
No, nothing dull.
So are they all adjusting to Kingman? You were here kind of through the heat of it all, so now
yeah, so cooler. I think we're adjusting. So we came from Minnesota.
Okay.
So we're looking forward to this winter, and hopefully it's not as cold as
up north. I'm a Minnesotan myself,
good.
so
it's good to hear.
Yes, I tell people this is my idea of a perfect winter. You'll be able to drive up into the wall of ice, have a snowball fight, build a snowman, and then drive back out of it.
Yes, we're looking forward to that.
You
after
can't do that
last
in
winter
Minnesota.
was very brutal.
It was brutal.
It was.
My kids, I still have a son and grandkids back there, and I have a weather alert on my phone, and I swear it went off every day last winter, either below zero, freezing temps or blizzards.
Yep.
There was like nothing temperate at all.
Yeah, that sums it up.
So, were you in Rochester? So you're part of the Mayo team?
Yep. So I trained, I was there for 5 years at Mayo Clinic.
Okay.
I did my residency there as well as a 1-year fellowship there.
Oh, excellent. And your fellowship was in pathology?
So my residency was pathology.
Okay.
And then my fellowship was cytopathology.
Was what?
Cytopathology.
What's that mean?
Well, so cytopathology is a subspecialty pathology where most of the time we look at cells that are taken from what's called a fine needle aspiration. So a very thin needle is put into like a tumor or a neoplasm, and then they take those cells, we put them on a microscope slide, and I take a look at them.
Okay.
And then also pap smears too is something we focused on.
Okay, very good. And so were you a Minnesotan before Mayo?
No, so I'm originally from Salt Lake City, Utah.
Okay, well, so you still kind of
So it's like coming back home here.
Yeah.
And then my wife's from a little small town called Vernal.
Okay, in Utah.
Smaller than this town, so she's very accustomed to small town life.
Very good, very good. We'd like to hear that. That's all good.
Yeah.
So pathology, I mean, how, as a young kid growing up in Utah, did you decide you wanted to go into pathology?
Yeah. Well, as a young kid, I never even knew what pathology was.
Yeah.
And so it was kind of a long road. So I went to Utah State University for my undergrad.
Okay.
During that time, I didn't know, when I first started, I wasn't sure what I wanted to do. So I had a couple things in mind, but I worked while I went to school. One of my jobs was working with mentally disabled adults, working in their home and helping them.
Like a caregiver type?
Yeah, as a caregiver, taking care of their needs.
Okay.
And so in that job kind of exposed me a little bit to healthcare. And as part of that job, I got a second job as a certified nurse's assistant.
Okay.
And again, I kept putting my toe deeper and deeper into the healthcare field, and I liked it, so I got more and more exposure to it and then decided to apply to medical school. And then in our medical school, again, you have a lot of options open to you. So there's many different specialties and fields out there. And I was open-minded. I didn't know what I wanted to do, but as I went through medical school, I was exposed to many different fields, and pathology just always struck me as something that was pretty neat and excited me. And that's how I got here today.
Awesome. Well, I know we're blessed to have you because we have Dr. Swap, of course. Did you know him from before you came?
Unfortunately. I'm joking.
No,
so Dr. Swap and I, we train, so we're in the same year of residency.
Okay.
And so I first met Dr. Swap, day one of residency, and we became good friends. And so we were together there 4 years, and then he came out here a year before I did.
Okay.
And then I came out
As
here.
you did your fellowship?
Correct,
Okay.
yep.
Okay. Very good. So now you're a team again.
Yep. We're back being a team.
Awesome. Well, that's great. And it's always good to have two of anything, so you've got kind of a backup in place, right?
Exactly. So for pathology, it's key to be able to have someone close by that you can trust, that you can share cases with, because oftentimes there's difficult cases, and it's good to have a second opinion
Close at hand.
Yeah, close at hand, that you can show a case to someone that you can trust, and so it's very nice to have Dr. Swap here as well.
That's, to me, and the microscope is like a whole nother world, and I don't know how I've only seen things like on CSI or TV, but to see the difference in how you're able to identify, good from bad, or
it's well, that's why we go 4 years. Yeah, 4 years of training, because I can say during medical school they really don't train you on how to distinguish good versus bad, benign versus cancer. And so you go to residency, and day one of residency, like you said, it was foreign to me as well, but during those 4 years and the 1 year fellowship, you get intensive training in how to recognize the different characteristics of the cells to be able to distinguish cancer versus something that's not cancer.
And is that pretty much what you focus on, is the cancer side of it?
That's probably what I spend most of my day doing, is with the microscope looking at slides from different patients. And a lot of it, that's the main question that clinicians have, is this cancer or not? But some other questions are, is this infectious? Is this an autoimmune process going on? So there's other questions too that we can answer looking at slides underneath the microscope.
Okay, so it's mostly tissue though then, right, that
Correct.
you're looking at versus blood, for instance?
Well, we also look at blood as well.
Okay.
So sometimes the clinicians will take a blood sample and they'll send it to us, and we'll take a look at that under the microscope as well. And so that's kind of what I spend most of my time doing, but also as pathologists, we're also responsible for overseeing the laboratory. So again, that clinician who takes a blood draw, typically that's sent to the laboratory to have different tests done. And we're responsible for making sure those tests are accurate.
Okay, so they kind of report back, or report to you as far as who's doing what tests?
Correct. So we oversee a lot of the technicians who run the test, and we oversee the machines that do the test. And so there's a lot of different parts of the machine, different parts of the processes that the technologists use to make sure everything is in order, and to make sure that patient receives a correct test result.
Sure, because obviously it's very critical to the patient to know for sure one way or the other. You wouldn't want them to get one diagnosis and then come back, oh, sorry.
Yeah, exactly.
Not a good thing.
So we do our best to make sure that doesn't happen.
Sure. Now, technology, you mentioned technology, and of course things have come a long ways over the last few years from a technology standpoint. So do you feel like there's a lot of new equipment that you didn't have in the past that we're using now?
In the laboratory, there's always new equipment, new machines coming out that can analyze blood better, or any other kind of specimens. And then also one of the big things with pathology is all the new genetic stuff coming out. And so that's a huge field that's still in its infancy.
As far as when you're saying genetics, so that's whether I'm as genetically predisposed to?
Well, so there's a lot of different applications that can be used with genetics.
Okay.
And again, genetics is basically looking at the person's DNA. And with those, we can help people tell, like you said, if they're at risk for a certain disease. Also, another exciting part of genetics is if a person has a cancer, we can see what kind of mutations that cancer has. And the hope is there's a lot of new drugs coming out that target those specific mutations. And so patients have a much better prognosis if they have those mutations and with these drugs that are targeted against these specific ones.
So you're really able to fine-tune it,
Correct.
the treatment
Correct.
of the cancer by knowing that.
And so these drugs are very more targeted just to the cancer, and so oftentimes you're not affecting normal cells. It's just attacking the cancer cells, and that's something that's very, like I said, it's still in its infancy, but it's very exciting.
I bet.
And there's already some drugs on the market with lung cancer, melanoma, and other cancers, and so far the results have been very promising.
Well, I would think that it's pretty exciting too from the patient standpoint. It sounds like what you're saying, that it's able to more directly just target that specific cancer cells, versus so they maybe don't have as many side effects.
Correct.
From other attacking other parts in their system.
Correct. And so with standard chemotherapy, oftentimes the chemotherapy damages other healthy tissue, and the hope is with these new molecular drugs that it just targets the cancer.
Awesome.
And so fewer side effects for the patients.
That's really cool, because I know even like on our cancer center side, from the radiology standpoint, you know, with our, I always forget, it's not 3 Tesla or the MRI. There's a special name for that.
Yeah, the 3 Tesla MRI.
That it's able to really pinpoint the tumor, which in the past, again, it would have been a broader attack, so you have more burnt tissue, surrounding areas, and that kind of stuff. So we're able to pinpoint it that way. And now with the chemo as well, that's pretty exciting stuff.
It is.
When you think of how it used to be.
It's very exciting, and you know, some of these drugs have shown great promise, not only reducing side effects, but also perhaps curing the patient. And so again, it's only still in the infancy. There's a lot of work, a lot of research that still has to be done. But again, that's one of the new technologies that's happening right now, and in the future will play a bigger role in what we do as pathologists and how we care for the patient.
Cool. Now, so how do you and Dr. Swap stay abreast of all that? I mean, you see him doing your job all day long.
Well,
medical journals or
so medical journals are key. We also go to conferences throughout the nation where we hear these different speakers and talks on these different topics.
And that goes back to Mayo too. That's kind of their basic philosophy, wasn't it? The brothers initially were getting out and learning from other physicians and getting educated. One stayed home, the other went out and swapped turns.
Yeah. So and that's kind of what we're doing here with Ryan Swap. You know, one of us will take turns and go out to a different place, and also we're blessed to have been trained at Mayo, where we have a great foundation, and at Mayo Clinic in Rochester, you know, they're at the forefront of all these new tests and new diagnostic and prognostic tests to help patients out. And so with Ryan Swap and I being trained at Mayo Clinic, we have a great foundation working with these physicians there, and we hope
network, I would imagine.
And a great network we can always communicate with, and we have a lot of good friends there who are some of the leading researchers and physicians there that we can always talk to. And
awesome.
And that's one way we can also stay abreast of all the new information out there.
Awesome. Well, and I know we have, of course, the ability for e-consult with Mayo here as well. I'm not sure how much that works for you guys, but
it's pretty similar. Typically with us, though, we'll just get on the phone and call or email one of our friends back there, and
you send them a picture. Have you seen this? I'm just kidding.
Well, sometimes with very difficult cases, we'll send cases out, and so there's always cases that may require a third opinion, and we just want
a head scratcher.
Yep, some head scratchers out there, and even in Little Kingman, there's things that require a third person to look at. Great.
We're going to take a quick break, and then we'll come back. So stay tuned. We have more to learn. I'll be back right after these messages.
So if someone did present with concern for Ebola with a travel history,
welcome back to Your Health Matters. My guest today is Dr. Brent Bedke, and he's the newest pathologist here at KRMC. Thanks again for being on the show.
Thanks for having me.
So we were talking before the break about genetics and how more and more that the DNA and all of that is becoming a pretty big, or has a potential to be a big player for pathology. Do you see that as kind of the future?
I do. I think in the future we'll see more and more genetic tests used in our diagnoses. And I think with that, hopefully we can use that information to better treat patients.
So is cancer that unique that it, I mean, for each individual, that it is impacted by our individual DNA? Because that's what makes us each different, right?
It's true. Also, certain cancers, we know from our research that certain cancers harbor different mutations. Some of those cancers harbor the same mutations. But there's also, each cancer may have thousands of mutations.
Wow.
And so part of the trouble with cancer is it's so complex. And the hope is we can find out which mutations are the bad ones that are actually causing the cancer to spread and grow. And in the future, we hope we can target those specific mutations to help treat the cancer.
So then obviously, because you're talking about treatment and being able to then pinpoint, so you must work very closely, not only with the oncologist, but probably like with pharmacy maybe, as far as helping identify the right drugs to be used? Am I on the right track there? I don't know.
Yeah, no, that's a great question. So in my day-to-day practice, not so much, but in those people who are researching the cancer.
Okay.
So back at Mayo Clinic, yes, there's a lot of communication between the researchers and pharmaceutical companies trying to develop these drugs.
Okay. And they are able to then hit or come up with drugs that are specific for that type. Okay, I guess I always thought that, you have lung cancer or you have brain cancer. Or, I didn't realize that each of those could have many different facets, right?
Yep, correct. So, there's cancer in different organs of the body.
Mm-hmm.
And sometimes those cancers will have, within one organ, will have the same mutation. Sometimes they don't.
To be different.
And so for lung cancer, again, when you classify something as lung cancer, there's many different types of lung cancer. So there's adenocarcinoma, squamous cell carcinoma, and many others. And so each of those subtypes of lung cancer may or may not have the same genetic mutation.
And which means they're going to react different to
correct.
the drugs that you're
correct.
sending at them.
Yeah, and so that's why pathology is important, is to pinpoint what subtype of lung cancer is it, and then go beyond that and identify which mutations are present in that specific cancer.
Okay, that's way cool. So do you find, we talked before the break too, you do not just tissue but also blood. You do blood workups as well. Have you had instances where you're able to help maybe in an early diagnosis of cancer where you're just doing blood work or something for another surgery, and then they find, does the cancer show up in your blood? How do you know?
Again, it depends on what kind of cancer. So there are certain blood cancers like leukemia that are present in the blood. And so those we can identify pretty easily off of blood smear and other studies that we do.
Kind of jumps out.
Well, yeah, sometimes they jump out. Sometimes they can be a little more sneaky.
Okay.
And again, we have to hunt.
So you're like a detective.
Well,
you really are.
To me, making the diagnosis is the most exciting of medical care.
Yeah.
And so and it's so pivotal too. Once a diagnosis is made, that leads to what kind of management that patient's going to have.
Sure.
So it's really
a
really pivotal point in the care of a patient.
Absolutely.
Is making the diagnosis.
So, are there tests that you can run for someone that says they have cancer?
So if someone has cancer, the best thing to do is go to their primary care clinician or their physician that they're comfortable with. Talk to that physician. If their clinician is concerned, and then there's certain tests that can be done, depending on what the symptoms are.
But I guess it's not something like, say, part of your yearly well woman exam. You go in and they run a test to see if you have cancer in your body or not.
Well,
at this time.
Well, it can be part of that. So like a pap smear is something that's done.
Yeah.
So that's a screening test looking for cancer.
Okay.
So a pap smear is done at an interval depending on the patient's age, and those cells will be sent to us, and then we can tell that patient that yes or no, you have dysplasia, which is a precursor to cancer, or if you have cancer, or whether it's benign.
Okay.
So yes, there are tests, and then part of a mammogram, if a lesion's picked up on mammogram, that radiologist will biopsy that, and then we can let the woman know whether that is cancer or not.
Okay, very good. So I kind of jumped ahead of you there. We started to talk about if you've had instances where you've been doing blood workup for a patient and identified other concerns other than maybe what they're there for.
Yeah, so that happens not too infrequently, where a patient comes to their clinician without a history of cancer, or there's no suspicion of cancer, and either on blood work or sometimes during surgery, where a surgeon may see something that looks a little funny and takes a biopsy of that and sends it to us. And then, I've had cases just recently where it wasn't suspected that this person had cancer, and we diagnosed cancer. And so that does happen.
And is it something they're able to do pretty quickly? I mean, I don't even know what his turnaround time is for a diagnosis.
Again, it can vary.
Yeah.
We try to be as quick as possible. So the process typically for a tissue biopsy is that tissue we sent to pathology. We will process that specimen. That usually takes about a day. And that process includes putting it into wax, cutting very thin sections, putting those thin sections onto a microscopic slide, and then giving the slide to us to look at.
Okay.
And so that process takes a day or two. And then sometimes if the diagnosis is straightforward, we can send that case out pretty quickly. But sometimes we have to do additional tests, and that can be another couple of days. And so it really does vary on the type of case that it is.
Okay, and what you're looking for, I would imagine too. So now we've talked earlier in the month with one of our healthcare providers about Ebola. So is that something that if for some reason we had someone present to our ER that had possible suspected Ebola, would then you be the one that would do the blood tests, or pathology does that?
So we're in charge for microbiology.
Okay.
And so Ebola is an infectious disease. Luckily, it has never been here at Kingman.
Right.
And so we don't have a test for that. And so if someone did present with concern for Ebola with a travel history, we will process that blood and then send it off to the CDC for their analysis.
So they're the ones that would do the testing to
Yeah, since they have the specific test to test for that, we would send it to the CDC.
Okay, that's why I was curious. I wasn't sure if that's what kind of a test is involved. Other than
typically, it's a very complex test called PCR is how they're running these, and so that's a specific test. And again, there can be different tests. There can be a test looking for the antibodies to Ebola, and those tests could be performed at the CDC.
Okay. Well, I just think it's really exciting. Like I said, to me, you're like, I just see you like with a sleuth hat on, and you're out there with your microscope trying to help identify and follow and look. And there's many different paths, obviously, that you could go down to try to make sure you find the right diagnosis, what's going on. And it is a pivotal part of a patient's care. Obviously, you can't really do anything until you know what it is you're trying to fix.
Correct.
So that's pretty cool.
Yes, it's very exciting, and every day there's always challenging cases and neat cases that have to make you think, and it's one of the exciting parts of my job is it never gets dull.
It sounds like it. You're always doing something different each case. So, like going down the road, we talked about DNA. Do you see other things in the future that might be changing for how you do your job in pathology?
Well, so like I said, we're a part of microbiology, and so also within that field, that's also changing pretty rapidly, where a lot of the molecular characteristics of these different bacterias or viruses, we're starting to use machines now that can recognize the specific subtypes of the bacteria or virus with a quick diagnosis. And so that's something too that's being utilized as well.
Awesome. Well, thank you again for being on the show today. I really appreciate it. It's good to get to know you more and learn more about what pathology is all about. So I hope you learned something new today. I know I did. Join me again next week and I'll have another great guest on the program.